Just be. Well, does anyone want to come around? So again, or keep that up a bit higher. So you're just obviously observing for any swelling, any change in that patellar position. Often just palpating that and just leaving those little dots. You can see that obviously the height of the patella is often different. Again, often when they're standing, you can look at one looking into the other. Often there is changes, but again, you can rule out a lot of nasties by the swipe test. Okay, so you can see there's no fluid. Can I just put my hand around your knee? If I just bring it there, and we push down. It's just called the patella tap. And if there's fluid in the knee, you can often find that there's more movement in that patella. Can I get you to lay flat on your back? Okay. Can I get you to bend this leg up as far as it comes? Good. And coming down, and then this one. Okay. Again, rough screen would tell you that there's no nasty meniscal pathology. And coming down. And again, I would just go through a few orthopedic tests. So I would just test the ACL, again PCL, and again, if it's lateral sided pain, I would put a valgus force on that. So we're just twisting the knee in, and again twisting the knee in there. Any pain with that? Okay. And again, palpating, obviously getting into that joint line and just running that across. You've got the MCL, and then pes anserine often down here, and a lot of the time you can actually feel the sort of saphenous nerve. I can't find it at the moment, and you can sort of follow that around into that sort of fat pad. So often a lot of teenage girls have that sort of non-specific pain there, but again, I think Alistair's point is sort of more there. So we then look at palpating. So palpating the medial border of the patella. We just press any of your pain there. Good. And again, where we'd think that sort of medial ligament would sort of sit. Good. And then nothing on that outside. Okay. Now the glides, generally the most useful one would be just that medial glide. So we're just bringing that across. Now generally we do that in about 30 degrees flexion. And obviously the more flexion you have...
So would you tape it in the 30 degrees flexion as well?
Yeah, so again that would be sort of held up there. And if anything, maybe when we glide that there, it does tilt up a little bit, but there's not a lot of resistance. We can do the glide up and the glide down. And again, if someone's had or reported any instability, the apprehension test is just gliding the knee laterally, okay, and it's that feeling that they'd say, oh, I don't like that, would obviously indicate that there's been some instability, and it's that structure here that would be obviously the torn structure. Okay, can I get you to kind of scoot up on the edge of the bed? Okay, now the Thomas test, probably a bit difficult on this bed, but it's a good tool, as I said, to assess some of those structures like the quadriceps, the vastus lateralis, that often are tight in these conditions. So generally the bed's a bit lower. We'd get someone to perch on the edge of the bed, and then we're rocking someone back to, I guess, let the leg hang. So can I get you to scoot a little bit further forward? Perfect. Now if you bring that leg up, if you hold that there, okay, so hold that with both hands. Okay, now we'll just get you to lie backwards, okay, and coming back. Okay, you okay there for the moment? Okay, just put this under through here. Okay, so in that position, you get the leg resting on the other leg. Now you can sort of, I guess, observe where her neutral pelvis is. So I guess we can sort of come up a little bit higher and observe where the ASIS is to say, well, that's neutral there for her. Okay, now just hold that. Okay, now in that position, just with that leg resting, again we're just looking at that static posture there. We're looking at the angle that the knee is in. Okay, And again, if anything, we can probably see that the hip flexors, maybe the iliopsoas and the quadricep are a bit tight. We bring the quad in, pretty flexible I'd say, and then we're looking at probably bringing the leg in this way. And again, we know that that's going to be, I guess, some stretch there, but we want to compare that between the sore and asymptomatic side. You bring that leg up, okay, and then this is your good leg, isn't it? It's a long day. So same thing. Again, we're looking at just getting that pelvis in the right position. Okay, there. And again, we're looking at that angle that quadricep makes, the compliance through here, and then obviously the compliance of the hamstring, and then often the ITB. And again, if there's a towel there, it doesn't sort of apply. So if anything, I'd probably say this side feels a bit tighter. Okay. So again, it's such a gut feel. You can look at the angle that it makes, or you can just sort of feel how much resistance you push and how it behaves. But if anything, that's obviously a little bit freer. Okay. Can I get you to scoot back on the bed for us? Okay, laying flat down for us. And again, bringing both legs up. Can I get you to lift your bottom off the bed? Okay, good. We're just getting a quick look at how the glutes work. And coming down. Now kicking this leg straight, bringing the bum up again. Okay, pretty good. And coming down, and then changing legs. Okay, coming up. So nothing too concerning there. Again, often it is that endurance and control with endurance. So, you know, how do we assess that in a clinic? Do we get her to do 50 single leg squats, or, you know, you can see it's obviously not too irritable. So you actually have to get into where it's sore. So again, I think it's so far not getting a lot of information. We can see that potentially that there's that extra dynamic valgus. Potentially there's a bit of weakness on the quads, a little bit more pronation on that side. But, you know, you're sort of going, well, what's causing all this pain with exercise? So again, you sort of have to keep working through it a little bit. But we can already see that we've ruled out a lot of the nasty things. So now what I do is probably look at, I guess, hopping for 10 times in a row and then observing any of that change there. Again, the strength of the adductors, you can measure it, but if you lay on your side, just that way, on your side to sleep position, yep. And then if you bring your leg out, okay, if you're resisting it here, it tends to be more the hip flexors, but out here and up, don't let me move you. So keep your legs still, don't let me push down. Okay, good. And often I guess for the sell to patients, you can actually use like a manual muscle tester and really push down there and say, you know, your sore hip, you don't have as much strength on your butt as the other one. And again, that's often all you'll find.
Yeah.
And you've ruled out anything nasty, but it's that control, especially when she fatigues and potentially you're running cell changes when you're getting tired, that may be putting more tension on that area. And again, obviously, getting that patient compliance is really important, because I think, obviously, looking at some exercises to work on the strengthening in that sort of landing where the leg's not getting into that valgus so much would be the thing that I think would fix her.
Yeah.
Okay. So let's just look at one more thing. Coming over to the wall here. Again, often if the hip's not a big contributor, and that you could say, well, maybe the calf is. So can I get you to face the wall? Hold your hands here. Okay. Now I want you to balance on this leg. Okay, and I want you to come up and down on your tippy toes 10 times, as fast as you can. Good. Okay, changing legs. 6, 7, 8, 9, 10. Okay, any change between sides? Okay, facing me on your right leg now. I want you to hop as high as you can 10 times in a row. Okay, really high. Okay, good. Now holding onto my hands for balance. Okay. Can I get you to balance on your right leg? And I want you to squat down as far as you can. Okay, and coming up. And again, as far as you can. And up. Last one. Okay, and then changing legs. And squatting down. And coming up. Okay, you can see a difference with that.
Yeah.
Okay. And then again, we're thinking potentially not a weakness in the glutes, it's that control. Okay, and potentially that's why she has more pronation in that foot when she's running. That lack of control is meaning she's coming into that posture and has obviously, you know, had some effect lower down.
Yeah.
So again, obviously exercise-wise, we're looking at training that with a mirror, and again, single leg squats often a really good way to start if it's not too painful. But as you would know, with anyone that's got an inflamed knee, it is. So again, it's that education, soft tissue work, and with Alice's case, you could see that you actually don't need to do a lot because her asymptomatic side's tighter.
Yeah.
So you'd be wasting your time if you were selling her a foam roller and telling her to do that. So again, I would think it's probably straight into the control of movement, but her mum's not going to pay for physio if you don't sell her something. So it has to be probably, yep, your kneecap's sore, tape it up, that feels better now when you do your squat, and then over that sort of load, getting that sort of landing single leg posture not to come in like this.
Yeah.
And that is that control of the hip. So
is that an awareness of what she's doing as opposed to a strength?
definitely.
Yeah.
So you know, I guess that's the thing. You know, that's feels natural for her to load like that.
She's actually breaking a habit almost.
Exactly. So again, if you can observe it in that posture, and you think, you know, after she's won the inter-schools and she's sprinting to the line and she's tired, you know, there's going to be more dynamic valgus. So it is a really hard one to treat, but again, you can see that sort of the biomechanics and that control do have a big play. And I guess from a structural sense, you don't know what's causing the pain. It's probably some medial structure in the knee that's getting stretched when she comes in. Okay, it's not her articular cartilage, it's not anything like that. Obviously, if it was acutely sore, I would think you know, low dye taping or something on that right foot would potentially unload the structures on a medial knee enough just to say, there you go, that feels better. But I would think it's missing the mark of just doing that.
Yeah.
So why wouldn't you strap it and then work on the hip flexors?
Definitely would. So that's what I was saying. So,
Okay, so a combination of the two.
definitely. So, you know, maybe in Alice's case, I would firstly just try low dye and, you know, like a little lunge in front of the mirror.
Sure.
And if that worked, you'd go, okay, that's going. You know, maybe in another case, I might go, if the medial glide was less painful, I would actually, you know, tape it and do something like that. So again, it's unloading a structure so it feels better, and then obviously that exercise progression.
The exercise, so say for example those lunges, what's, provided the patient's compliant with doing exercises, what's the sort of, you know, is it 2 weeks that they should be noticing improvement? What's the likely?
It depends on how long they've had the symptoms usually. So the basic rule would be how long someone's had symptoms, that's how long it's going to take to get better. So it's a tricky one with chronic problems, and again, I would think it's such a hard problem to treat because often they don't get a lot of pain relief, and it's just, you know, later on, a year later, that they would say, oh, you know, my knee's sore, but then I do my exercises again and then it feels better. Would be the typical case. And there's no cause effect because, you know, if the knee gets inflamed, it's inflamed, and, you know, general rice will help it. But you need to be treating the underlying biomechanics and underlying control to keep it good longer term. Okay.
Do you think there's any role for kinesio taping as far as?
I don't like it, but definitely it does have a role. And again, that compliance and potentially muscle recruitment can be influenced by having a bit of tape there. Again, I haven't used it, but I know a lot of my colleagues do.
And what would they do in this case? Over the
Generally-
glutes?
Generally, what they do is they do sort of like a facilitation tape on the VMO.
Mm-hmm.
And again, you're just putting that muscle under a bit of pre-stretch, so that as they're walking, they're going, okay, hold that, rather than "Ooh, let it go in.
Mhm.
And it's maybe just a forced awareness, I would think. But again, the less the knee comes in here with loading, the less pain
Yeah.
Alice is going to get.
So you wouldn't look at
I
Around
don't
the
actually
hip?
know how to tape the hip. I've never done it. I think I've done it for the GT bursitis, but again, I've made a point to stay away from it because I prefer to do other things.
yeah, no, that's fair enough.
Um,
Just wondering.
Yeah, but there could be a case to be made that getting some awareness of firing and control of that glute when you're loading that leg does have a big play.
Mm.
And my partner always makes fun of me about being a physio sometimes, because when she went to a physio once, she was told to squeeze a button. And the physio said, every time you're in the cashier line, squeeze your butt. So we always have a giggle. So. But again, that awareness of, as you're loading, if you've got that, control through
Yeah.
your glutes, your knee's not going to fall in because you've got that as a stabiliser.
Yeah,
I've just remembered McConnell's test.
yeah.
Sorry guys, come have a seat up on the bed. Thanks. Okay, so McConnell's test is, I guess, something that's good again to show the patient that maybe the patella tracking is something to do with their pain, and again the pain should be better quickly. Okay, so generally what you'll find is different ranges of motion will cause, I guess, loading through that knee. So if you bring your leg up straight, now keeping that still, don't let me push down, so nice and strong. Good, excellent. Any pain with that? Good. And then bending your knee, so I'd probably go next to that 30. Nice and strong, don't let me move you. Excellent. And then coming down and pushing nice and strong. And relax. And then here, nice and strong. Okay. Now again, you can do sort of, I guess, the eccentric component. And again, you're looking for that tracking, I guess. And then it actually looks all right. So just hold your knee straight and slowly let me bend your knee. Good. And again, often you can see that sort of deviate a little bit, but again, in Alice's case, it doesn't actually look like that lateral tracking's a big thing. Well, I wouldn't think it is, but relatively tracking when her knee's in that dynamic valgus, it is. And that could be, in her case, because she's got really lax knees, and that ligament here lets her knee bow in more than someone else's would, and that's causing, I guess, lateral tracking. She's not symptomatic on there, but it's that stretch through those soft tissue restraints. So again, I think I can see why this has gone on for a little while because it's tricky. But basically, what I would think, Alice, is when you're running, I think when you'd probably start up, you look really good. But I'd imagine when you're getting a bit tired, you would people may call you knocky knees. So I think if we can fix your running so that your knees stay straighter when you're running, it's not going to put as much pressure on that area. Okay, and as I said, we've been talking about the muscles up here stop your knee from knocking in. Okay, and if you can get the idea of how to keep your knee straight and tracking straight when you're running, I think it's going to have a big help. But the problem is you have to do exercises. Okay, there's nothing else that you can really do. I think if it's sore, taping may help, the orthotics may help, but it's probably looking at your balance and your ability to squat on one leg and having that between the same. Does that make sense? Sort of? No, you'd be directing that at Mum. But again, you know, this is where I find it hard, because that may not make sense to someone, and you know, they'll go to someone who does ultrasound, and it makes it feel better. But you can see it's a biomechanical problem, and often that loading and the load management needs to be pivotal for it to get better. And no one wants to stop playing sport, but if that's re-aggravating and making it sore, I would think that has to be done. Okay. Can I show you one exercise? Okay. Okay. Now we're going to put this band around your knees. Okay. So let's have a seat up on the bed first. And again, the reason we do this is because if we tie it around, it just gives Alice something to, I guess, abduct it against. And then when she's doing the squat, she can feel that sort of pressure out. So really simple exercise. Doesn't work as well when they're hairy footballers.
No, they wouldn't like you very much.
Okay. Now again, standing up for us. Okay. Now, often it just feels a bit better just below the knee. Okay. Now, can I get you to stand facing that way? Okay. Now I'm going to get this here. Okay. Now I want you to pretend that you're going to have to sit on that stool. So move your feet back a bit. Good. Okay. Now feet just wide enough, what feels normal for you. Okay. And again, I want you to pretend you're going to sit down on that seat. Yeah. Just hover your bum just above and coming up. Okay. Now you can see what happens on that right side. Try that again.
Yeah.
Good, and coming up. Again, I think that visual cue of the mirror is important because you can see it pretty obviously. So this time, I want you to see that your right knee's coming out a little bit more, and then just holding that to come in. That didn't really make sense, but we'll see if that worked. So again, keeping this knee as you bend down, coming over the back. That's it. Yep. So good, really good. Okay. And can I get you to step forward with this knee? The right one. Perfect. Okay. Now just balance yourself up where you're comfortable. Perfect. Karate stance. Good. Yep. Perfect. Now the middle of your knee here, I want that to go over this toe. So I want you to bend your knee forward. Excellent. And coming back. Okay. You've got that one? Okay. Now I want you to be really focused, and I want you to do that 5 times in a row. Okay. Okay, maybe that TheraBand's annoying, the issue. Just take that off for us.
And
But
just
again,
slip
it
it
just
off.
does, I guess it facilitates that hip abduction and sort of allows to push out against. But again, if you're getting your foot tracking there, your glute's firing as well. If it's falling in, it's not holding the leg in the right position. So see how your knee wants to come here? Okay, your knee's made to go out there. That's better. Okay, and again, often that can be a bit sore, but getting your knee strong over your foot is going to help you. Okay? You can already see if she had tightness in the ankle joint, it's going to impair it. You could see if the subtalar joint's stiff, it's going to impair the mechanics higher up. So again, often you're treating treating muscle tightness, you're treating the joint restriction as well, and those moves do help. So can I get you to do 10 good ones in a row? Perfect. 1, 2, 3. Last one. Quick 10. Now can I get you to balance on that right leg for me? Okay. Now this is going to be harder. See how your knee wants to come in here? I want you to get your knee out over there. Whoa. Okay, you can hold your hand there. Beautiful. Again, a quick 10. Does that feel weird? Okay. Excellent. Okay. Now can I get you to jump up on that box? Okay, facing me. Okay. Now I want you to land with your body forward. So land this. Good. Okay, simple landing. I guess I'll just illustrate it. If people are landing with their trunk upright, okay, the force gets absorbed through their knee. If you're landing in some hip flexion, okay, the force gets absorbed through your butt. Okay, and again, often with basketballers, that can make a big difference. You know, after the rebound, they're landing really upright. Just after they take the rebound, land with their trunk flexed can often be a big thing. And the load's just shared a little bit. Okay. Now for Alice, if her pain was with landing or jumping, you'd have to train that into that progression. So once she's got that control of the single leg squat, you know, often doing a step up with that control, you would then progress it into landing. So let's get you to jump up in here again. Okay. Now can I get you to jump off and land? Yep. Good. Okay. Now jumping up again. Now I want you to face the camera. I want you to land a little bit deeper, so you're landing like this. Beautiful. Okay. One more time. What I saw then is I saw when you landed, your knee fell in a little bit. So just see if you can land deep with your knees out strong. Better? Good. Okay. And one more time. You might be preventing a future ACL injury here. Good. One more time. And a little bit deeper this time. Beautiful. That looks good. Now can I get you to hop up, and I want you to land on your right leg. So jump, land on your right. Beautiful. Okay, try again. Try it, see if you can do that deeper landing. Okay, now I saw your knee twisting again. Try again. And the mirror has to be here.
Yeah,
Because
she can't tell.
better. One more time. And then we'll let you off with some slack. Better. Okay. Thanks for being such a good patient.